call upon Ravi Mansur to facilitate our speakers and chairperson. Makar, can you take the pics for your call upon Ravi Mansur to facilitate our speakers and chairperson? Small session, Dr. Makar, we can have some, right? So now moving fast to the second case. So as a physicians, we are left with patients with fevers, and sometimes fevers are big headaches for physicians, and we all know, right? We have presented cases in the past as well, right? We don't know the cause and a lot of things investigated. The issue that in the corporate setup, we have all the facilities, right? We can do a PET CT, we can do a bone marrow, we can do everything. Like, but in a center, small centers, or in a clinic, sometimes patient comes, it's very difficult to evaluate and all. But there is always learning that if we are stuck up somewhere, that we should refer it early, right? Because sometimes the fever can take a very bad turn, and patient might succumb to his illness and without having any diagnosis. So I think this is a forum that we actually present such cases so that we are aware that what should be the approach to the patient. We may be wrong or right, but what we have done is right or wrong. But this actually we have done, and that's why we're presenting to know that where we were wrong and where we were right. But I think with this, I request our third resident, Dr. Suman Biswas, to present this case, and we'll have questions answered in between, right? So I think this is a domain of physicians, right? How you approach the case or difficult fevers, right? As at presentation. So.
Good afternoon, sir. Good afternoon to all seniors. I am Dr. Sohan Biswas, third year internal medicine resident. In Max Vaishali. My moderator for today's case is Dr. P.N. Chaudhary, sir. So today's case is for the difficult case of fever with rash. The patient earlier went to 2 medical colleges and was finally diagnosed in our hospital. So the patient is a 17-year-old male patient with average built-in nutrition, BMI of 23, student by occupation, residents of Aligarh, Muslim by religion, and unmarried. So the patient was apparently well before 30th of June when he developed rash. He developed a pruritic rash all over the body from the morning of 30th June, followed by high-grade fever, mild sore throat, severe body ache, and back pain from the evening of 30th of June. So basically on the morning, he developed a pruritic rash, and from the evening, he started developing fever, sore throat, back pain, and body ache. The fever was continuous in nature with a Tmax of 104 with chills, no diurnal variation, not returning to the baseline even with antipyretics, and was associated with severe body ache and back pain. The rash was a diffuse maculopapular rash distributed throughout the body, more distributed in the trunk than limbs, and was associated with severe itching. The patient consulted a local physician to be prescribed medication for 7 days. The patient could not present the prescription, so the nature of the medications was unknown to us, but the patient did not get any relief. He then consulted the Jawaharlal Nehru Medical College, Aligarh Muslim University, on the 11th of July. The patient was admitted for 1 day in JNMCH Aligarh and was referred to AIIMS New Delhi or Safdarjung Hospital. The patient could not get admitted in AIIMS New Delhi and was admitted on 12th of July in Safdarjung Hospital as a case of sepsis with quarry leukemoid reaction. The patient was admitted for 3 days in Safdarjung Hospital and went Lama on 15th of July and came to Max Vaishali for further management. So the chief complaint at the time of presentation to Max Vaishali was a high-grade fever, persistent for the last 16 days, diffuse rash all over the body with severe itching, severe body ache, severe back pain, and mild sore throat. There was no associated respiratory complaint or GI complaint or burning micturition or any visual or hearing disturbances or any history of weight loss. The vitals at the time of admission was largely unremarkable, except the patient was febrile with a 104-degree temperature. There was no icterus, no cyanosis, no clubbing, no pedal edema. Right inguinal lymph nodes were palpable, non-tender, and there was a diffuse maculopapular rash all over the body with distribution trunk more than limbs. There was no eschar. It was largely unremarkable, except the liver was palpable 2 centimeters below the costal margin. There is no similar illness in the past, no past history of any hospitalization, no surgical history, and there was no comorbidities. No, sir, no contacts. There was no smoking history, no alcohol history, no IV. Abuse or high risk behavior, no medication history, no allergic, and no alteration in patient went for swimming in a local for the onset of fever. Now, the initial investigation reports from the Aligarh Muslim University were as follows. The patient put a high TLC count of 61,000 and HB of 10.9. Rest kidney function was all normal. Liver function was largely normal except an elevated alkaline phosphatase of 157. The urine reports were normal. The dengue serology was negative. The peripheral smear showed normocytic normochromic and moderate degree of leukocytosis with toxic granules. There were no immature cells and no hemoparasite. So by this time, we know that the patient is having a high TLC count. So looking at a 61,000 TLC, our first differential will be either the patient is in sepsis or the patient could be in a leukemia. But the peripheral smear does not show any blast cells or any immature cells, and it in fact shows toxic granules. So we go more towards the favor of sepsis. We don't have the differential counts at this stage.
Are you there?
Anvita ma'am. Any we did it in our hospital, sir. But we don't have the prior reports. went back to 73. There was progressive drop in hemoglobin from 10.9 to 9.7. The kidney function was normal. The liver function showed a deterioration with mild transaminitis of 104 by 34 and a progressive rise in the alkaline phosphatase of 166, 213, and 296 with hypoalbuminemia. The urine routine was normal. Viral markers were non-reactive. The dermatology opinion was taken for the rash, opined for query drug-induced query viral exanthem. And an ENT opinion was also taken for the sore throat, which opined for mild congestion in the tonsillar pillar. The patient was treated with cefoperazone, sulbactam, and amikacin, and later changed to meropenem and doxycycline. The patient was admitted for 3 days in Safdarjung Hospital, but the patient continued to have high-grade fever, and the patient continued to have high TLC with progressive drop in HB. And the patient went Lama from the Safdarjung Hospital on 15th of July and got admitted in Max Vaishali on 16th. Now, on admission to Max Vaishali, we continued with the same antibiotics. We continued with meropenem and doxycycline along with other supportive measures. Our initial investigation reports are as follows. The TLC count was high of 50,000. The differential was an 84% neutrophils and an HB of 8.5. So looking at this picture and the corroborating the earlier peripheral smears, so it likely looked like we are dealing with a case of bacterial sepsis. The liver function was normal and the alkaline phosphatase was 116. The KFT was normal. The CRP was high, 319, and the procal was 4.15, which again suggested that we are dealing with a case of bacterial sepsis. The urine routine was normal. The INR was deranged, slightly deranged of 1.58. Dengue was negative, malaria was negative, scrub, lepto, Vitelix was also negative. Peripheral smear pointed towards sepsis with toxic neutrophilic leukocytosis. The chest hepatomegaly. But due to persistent high-grade fever and unable to find the cause of the fever, the patient was planned for bone marrow examination on 16th of July. And an hematology consult was also taken, who advised for RA factor and serum ferritin levels along with the bone marrow aspiration.
Blood culture, sir?
Yes, sir. The next day reports are as follows. The typhoid came negative. The Vidal was borderline positive, 1:160 titer, and the ANA was negative. The bone marrow aspiration report showed adequate trilineage hematopoiesis with milder preponderance and reactive changes. There was no blast or no abnormal cells. So by this time, we were clear that we are not dealing with any hematological disorder. We are dealing with a case of bacterial sepsis, and the bone marrow report corroborated the same. The patient continued to have high-grade fever and was empirically started on artesunate from 18th of July along with meropenem and doxycycline. The next day, the report, both the cultures came sterile. The CRP mildly dropped from 390 to 290. Were negative. The iron study shows anemia of chronic picture. The stool OB was negative because of the chronic and severe body ache. The CPK levels were also sent, which was largely normal. The RX factors came negative, but the ferritin came as high as near 10,000 level. So looking at this picture of a high lipomoid reaction and a high 10,000 level ferritin, so we had differential diagnosis in mind here of HLH or actochrome, but the bone marrow report shows no hemophagocytes and there was no cytopenia except the HB. You need 2 cytopenias. There was only 1. So the HLH and marrow disease, and this is the criteria for adult onset. Like the still disease rash is non-pruritic. Here the rash was pruritic. So that was one of the points that pointed in negative of still disease. The WBC was more than 10,000 with more than 80% neutrophil. There was sore throat, there was lymphadenopathy, there was abnormal LFT, and there was negative ANA. But onset stage disease, the typical ferritin levels are in the range of 3 to 5,000. 9,000, 10,000 ferritin levels are usually seen. So we took the consultation of rheumatology for this matter as well, and they also opined for the same, that this is not a case of still disease, it's a case of bacterial sepsis. Sir?
I actually admitted board and I have high fever, unfit fever. We could not even localize it. Definitely the microbial rash was there, itchy rash was there, and patient had high counts. Yes, he was very high, 70,000 between, and some toxic animals. We could think of no acute metabolic malignancy, but bone marrow was done and did not show any. Did not show any abnormal cells. So I think that's dealing with some sort of sepsis, bacterial sepsis, possibly because of some recommendation there. We got thought of HLH also, because HLH, but there are cytopenia in HLH, not because hydrosis. There's cytopenias and cystocytes in bone marrow was not there, and no signs of myelofibrosis in bone marrow. We considered one case of HLH before also. We showed that the myelofibrosis was there. There was retinal very high, 1,000. So, patient sepsis, high grade fever, toxic, right, high counts, and not responding to anything. We take their meropenem for there, and so we thought that we could do some biopsy from that. Okay, we could get something like some chemical something. Actually, biopsy was also planned, but different like this. So no, nothing was found for the infection, and PET-CT did not show anything. PET-CT was done and showed just lymph nodes, so different lymph, and nothing very specific came out in the PET-CT findings. The lymph node biopsy was done and it showed the active thing. Could not find out. So we understood that we are not doing nothing. The patient had been gone from Aligarh to AIMS to Savila Hospital, and for something that he referred to us, and we did think, and it was a pattern of TLC from 7.7. It is persistently higher. And the hemoglobin pattern is there. So I think we also sent Brucella also, right? And Brucella report came out later on.
Yes, sir.
So patient had some fall in hemoglobin also, and we did potentially to lots of occult. Practically was not some solidarity was there.
Yes, sir.
After third day, Brucella was. So we just asked the patient retrospectively that he used to have some unprocessed milk. He said that sometimes he used to have. So we thought that patient had some swimming pool, some infection was there, some Legionella or some lice, but it actually was not there. So Brucella test came out to be positive. And this report came when the PET-CT was already done, because it take I think two days time to take serology, and it was positive. They have not mentioned titers, because they should mention titers. Only serology can be counted positive. Next.
After the Brucella IgM came positive, the patient was continued on meropenem and doxycycline, and as per the protocol, the rifampicin and gentamicin was added. And in view of the fungal esophagitis on endoscopy, fluconazole was started. So by this time, the patient was on meropenem, doxycycline, rifampicin, gentamicin, and fluconazole. Artesunate we stopped after 5 days.
Chill program was very high.
4.19, sir. 0.79. No, sir. This is along with meropenem and doxycycline. So probably we concluded that since doxycycline is the drug of choice for Brucella, so it.
Doctor was not taking in VMC also.
1 day before coming.
I have a question. Right from day one, when you suspecting Brucella, why did you start doxycycline from the day one? That is my question. Because Brucella, yeah. So we said in all the cases of sepsis, shall we give doxycycline from the day one?
No, sir.
That is what my question is.
Doxycycline was not started even. Patient was already on neovenom. Yes, but patient was not responding. So we said that some infection going on, so we started doxycycline.
As a general practitioner, shall we start doxycycline along with
It was started something itself, so we continued with doxycycline. Okay, doxycycline, we started just continued doxycycline because scrub and everything. Now we see a lot of cases of scrub because I have with high program.
It's a nice idea. Doxycycline आपने day one से शुरू कर
One
दिया.
case, not day one, sir.
Dr. Tiwari,
हाँ
you're
sir.
right, you have a point. If your fever is not responding after 2 weeks, you can start doxycycline.
वही ना सर. Physician के तो दालों की fever है.
So doxy is a very good drug.
In fact,
After 2 weeks, you
It's a massive form.
in fact, patient was giving artefact as well.
नहीं, वो तो मलेरिया के लिए सभी दे देते हैं. लेकिन doxycycline is a very good point.
In fact,
अभी तक तो सर एसिडिटी के लिए बट रन के बाद
typhus and
neurological manifestations were there. So, there is a special addition of doxycycline. Whole book is on doxycycline.
exactly.
Right. So, we have seen there are a lot of things multi broad spectrum antibiotics.
So what is the final diagnosis?
मैं भी अभी शुरू कर
Sir, brucellosis with fungal
Sir, no, there is no
hepatitis.
final. Sir, there is no final diagnosis.
But this was not diagnostic.
So, Brucella actually, Brucella is there, but Brucella is very underwriting course. Patient is not very severe in Brucella, there is leukopenia, sir. There is no leukocytosis.
Leukocytosis नहीं हो.
Normally, Brucella is considered leukopenia, sir, not leukocytosis. And if you search literature, I could not find anything Brucella certain leukocytosis, वो भी in the leukocyte reaction. In all 7,000 plus. So it's a very type of case. Maybe patient may not be a Brucella, right? But patient responded to the treatment, maybe doxycycline, maybe rifampicin. But if you have some Brucella serology positive, but we have started rifampicin and patient responded to that. Patient called doxycycline open up or patient responded to rifampicin. Doxycycline was involved. Right. So it was a difficult case for us because so much high counts and the patient followed by the OPD. We just quickly asking him that the patient will follow. Patient had to find NAMA because of the financial necessity. Patient was Max Hospital. The patient, but they are following. The patient was being followed in the OPD medicine. And gradually the TLC came down and patient became afebrile and now he's absolutely fine. So the follow-up.
So the patient did followed up with the OPD. We continue to call that, are you responding? What about the fever? In fact, we used to call every third day ki, are you responding? And they used to send us their lab report. Finally, the patient resolved with
So in this case, it's very important follow-up. Okay, patient is not being followed in the hospital, but we followed the patient in the OPD. And we asked asking that what is their experience the patient is
How
responding.
long did you give doxy?
So 3 weeks. 3 weeks. 3 weeks. In patient, the guidelines that you give doxycycline when it comes to 3 weeks. In patient, immunocompetent patient, that should be given for more than 3 to 6 weeks duration. The patient immunocompetent,
Doxy 100 BD.
200 milligram, 100 milligram per liter. So just 2 or 3 slides on literature, then we'll finish up.
So brucellosis is also called as undulant fever because of the nature of the fever, that it's a waxing and waning type of fever. It mimics like the tuberculosis. It comes in the evening along with night sweats, and by the morning it resolves. And sometimes it persists for a week, and then over a long period, the patient remains afebrile, and then suddenly the fever comes and it stays for 1 week. So it's an undulant fever. It is transmitted to humans by consuming unpasteurized milk. So we'll shift to the treatment primarily. The CDC and the WHO recommended first line treatment is doxycycline 100 BD plus rifampicin 600 to 900 for 6 weeks. So the drug of choice is doxycycline, but with a monotherapy doxycycline therapy, the relapse rate is as high as 40 to 50%. To combat with the relapse, we add rifampicin, and the total duration, the minimum duration is of 6 weeks. This is for an acute uncomplicated brucellosis. If the patient is having complications like a neurobrucellosis or endocarditis or spondylitis, then the treatment is doxycycline, rifampicin, and monotherapy to 12 weeks. And the same goes for an immunocompromised patient as well. In the special population in a pregnancy, we can't give doxycycline, so we give rifampicin, and from the second trimester onwards, you can add a 4 trimestazole. Same for children, we can't give doxycycline, so the combination is rifampicin plus sulfonylurea. And the post-exposure prophylaxis is also doxy plus rifampicin for 3 weeks. Overall mortality is very low, less than 5%.
So that is a learning for everyone, right?
Yeah, one of the slides you showed you, but I was positive,
Yes.
year got. Could it be,
Sir, enteric fever, enteric actually can present anything except MI such in this handbook and some textbook.
But it's not without.
So enteric fever can present, but cultures did not show anything. Plus, we just asked that follow up, this thing, Vidal follow up, try to see the titers, increase titers, right? So investigation are already there, but patient doesn't look like enteric. Patient normally enteric, there's no cytosis. Patient has very high fever.
Actually, for that matter.
It's not the bonus, it's bonus ceftriaxone and nebulizer. So enteric would have responded to that.
Because even fruits were not there, steam was not there.
Yeah, right.
And
You are the students. So, thank you so much for excellent rendition. So, it's a result, and I think it's a good result. And I was that I will not to consider with planter और मकरों उनको बुलाएंगे सर उनके साथ कुछ और हम करिए
But एक चीज पूछनी है, what type की negative और Vidal positive, importance क्या है?
बस इम्पोर्टेंट टाइफाइड इज which are majority infections all standard or is again is better or serial rise of factors that's not waste of money it is good for keep purpose.
Very good. Very good.
So I also request Dr. Pandit sir, your Dr. A.K. Pandit sir has organized a very beautiful conference of cardiology, and he has involved each and every member of BDP works. So I request Dr. Pandit sir to come forward and receive a bouquet from someone. And
it was a very, very successful.
and I think very innovative ideas. Sir, it is this collaboration of different subspecialties like cardio, neurology, cardio gastroenterology, cardio obstetrics, right? I think that's important. So this is a very multidisciplinary